everyone. So without wasting any more time, let's call Dr. Abhishek Patil, who will talk on Sjogren's syndrome in Asian Indian patients. What is unique?
Thank you, sir. And at the outset, I would like to thank the organizers for allowing certain rheumatologist at Manipal, Bangalore. And let me use the phone. And this will be the outline of the talk today. We are going to run through pathophysiology as relevant to the current topic and epidemiology, moving to genetics to find out if there are any unique genes in Asian patients, and finally the main component, that is how the Sjogren's manifest differently in Indian patient. So as come to the pathogenesis part of it, we need to understand that Sjogren's syndrome, we all understand that it is autoimmune epitheliitis of the exocrine glands. Basically the salivary epithelial cells is just not a soft target of the immune attack, but it also plays an important pathophysiological role. So basically this salivary epithelial cell itself is intrinsically abnormal. So that is why it secretes less amount of saliva along with immune attack. It also acts as an antigen presenting cell to the infiltrating T and B cells, and does act as help in the formation of germinal complex and propagation of the inflammation. So salivary epithelial cells play a key role in the pathogenesis of Sjogren's syndrome. This is the newer concept that we are coming to. Coming to epidemiology itself, Sjogren was believed to be very rare in India. From Asian cohort, we have about prevalence which is much lesser than the European cohort. The maximum data regarding Sjogren's come from the European cohort, where they describe even up to 1% of the population suffering from Sjogren's. But coming to Chinese and Japanese cohort, the prevalence is much lesser. The lowest prevalence reported from the Japanese population. However, from India, the data was sparse up until the last decade. Between 1990 to 2000, the SGPGI study, which reviewed their charts, found were able to dig up only 26 cases of Sjogren's syndrome. Whereas in the same period, they described thousands of patients with rheumatoid and several hundreds of lupus patients. However, this all changed when we had retrospective analysis from CMC, where the authors were able to describe over 330 patients over a period of 7 years from 2004 to 11, indicating that Sjogren's is not so rare in India. And there are several studies thereafter, predominantly coming from the South India. I'm sure my eminent co-speaker will highlight more on that. Now, coming to the pathophysiological, so this is important to understand what we are talking about. The Sjogren's syndrome can itself manifest in 3 different forms. It can have a definite glandular variant, where there is a very little immune activation. It's predominantly a glandular dysfunction occurring in the salivary epithelial cells, very little interferon signature, very little infiltrating Th17 cells, not much of germinal center formation, and these are the patients who present typically with dry eyes, dry mouth. What is important to understand, maybe these patients are not coming to rheumatologists. Then you have on the other end, other extreme, an immune complex mediated disease where there is a very powerful activation of the inflammatory infiltrate, germinal center formation. These are the patients who exhibit high levels of IL-17 interferon levels, high positivity for Rho-La antibodies, and probably these are the patients who have cutaneous vasculitis, arthritis, neurological complications of Sjogren's syndrome. In between lies a very epithelial kind of a presentation where patients have some immune activation. These are the patients who have tubular interstitial nephritis or cholangitis or the bronchiolitis. So whenever we talk about Sjogren's, these are the 3 pathophysiological groups we need to keep in mind And probably what ends up, happening to, rheumatologists is they probably end up seeing these patients and miss on these patients. So this may be reflecting in the, prevalence of the manifestations and other things that I'm going to discuss with you in coming slides. So genetic studies, we don't have any good genetic study from India, but when you extrapolate from the Asian and Japanese cohort, you will find nearly the similar kind of genetic susceptible loci. These are HLA DR3, DR4 loci. DR4 seems to be more predominant in the Japanese population, whereas European cohort HLA DR3 is quite common. These are nothing but the MHC complexes which present the antigen to the to the infiltrating T cells. So these are commonly involved, and then we have this classical genetic foci of classical autoimmune diseases like interleukin 12, STAT4, and human necrosis factor infecting proteins. Similar kind of genes are reported from the Asian cohorts as well. One specific which was not found in European cohort with the Asian patients is a generalized transcription factor, but apart from that, it's nearly the same risk foci. Now coming to the focus of today's talk, that is about clinical manifestation, how it's different. I'll start with the Asian patient. There are three large Chinese cohorts which are which were done from 1985 to 2014, and they describe the patients to have with several important differences compared to their European counterparts. First of all, the patients were a decade younger. The mean age of presentation was about 40 years. The patients had less of Sitka as the presenting feature. The patients had a lot of neurological and pulmonary and renal manifestations. So about 8 to 10% of patients in their cohort had renal tubular acidosis, which is much higher than described in the European population, and they had a lower prevalence of Raynaud's and fatigue. And very interestingly, most of the case series or case reports of protein-losing enteropathy come from Japanese population with Sjogren'S syndrome. So now I'll come back to the CMC study that I was talking about, and here also mean age was younger than the European counterparts, a staggering female to male preponderance of 18:1. And again, for Indian patients, Zika was presenting symptom only in about 8% of patients. Interestingly, these patients have very less hypergammaglobulinemia, no cryoglobulinemia in about 69 patients where it was tested, and renal tubular acidosis, just akin to their South Asian counterparts, were quite high. And importantly, they used something called Phi coefficient to correlate between the various categorical variables, and they were able to give two different clusters of patients. One cluster of patients who had a very high ROLA antibody positivity. These are the patients who had very significant vasculitis, arthritis, neurological complications, and they were the patients with low titer or absent ROLA antibodies, and these are the patients who presented with Zika, arthralgia, chronic pain, and parotidogmegalia. So they were able to give these two cohorts of the patients. Then moving on to another study from a premier institute in South India, and they described about 70 patients. Remember, these patients were prospectively followed up over a period of 2 years from 2014 to 16, and they found that these patients, about 50% of them had some of these 70 out of 70 patients, but 50% of the patients had some of the other renal manifestations. Many of them had renal tubular acidosis, about 35% of these patients. And the authors described this high incidence, probably because of the referral bias towards the tertiary care center, prospective analysis. But so you can see already that this pattern is consistent, that renal involvement is far more common in our patients. And when they compared renal Sjogren'S versus non-renal Sjogren'S, that is 35 each in group, they found that renal Sjogren's patients had lower Zika, lower arthritis. Remember the second slide that I showed, pathophysiological classification, that renal manifestations are more often immune complex mediated manifestations, so that is why they don't correlate with the glandular manifestation. And these patients had greater parotid swelling, greater vasculitis, and much higher disease activity index called PSSDI. And there was another study from Chennai, which between 2013 to 15 they described about 82 patients, and they categorized the patients as glandular versus extraglandular. And when they studied, again, this pattern remained consistent, that those patients who had a extraglandular manifestations had much higher ESSKI presentation. They were younger. They were about 10 years younger compared to their counterparts who had predominantly presented with Sika features. Now, regarding secondary Sjogren's syndrome, there is not much data. There is one study published from PJ Chandigarh, where the authors used objective measures, that is salivary scintigraphy and Shermer's test, to confirm the presence of Sjogren's, and they found that about 5% of the patients with rheumatoid have Sjogren's, and understandably these patients with rheumatoid with Sjogren's were older and had a longer duration of disease. And then there was an abstract presented to the EULAR by Dr. Sonal, and this was based on clinician determination, not objective measurement, and about 25% of patients with rheumatoid complained of significant Sjogren's syndrome. So now moving on to lab investigations, I put two major studies from India on the left and two Italian studies on the right side to find out, to highlight the differences. Actually, there is not much of a difference here. We can see most of the autoantibodies are similar in prevalence from our cohort compared to the European cohorts. However, one striking observation is the absolute absence of cryoglobulins, as I mentioned in the first part of the presentation. And hypergammaglobulinemia is far less prevalent in our patients compared to European population. Then there was a big data Sjogren's project consortium, which was recently published in Annals of Rheumatic Diseases. Here, the authors contacted the different investigators from across the globe, and they were able to assimilate data of about 8,000 plus patients, and they tried to differentiate them based on geographical location. And what they found is what I've been talking about so far, that in white population, Sika as a presenting manifestation is far more common compared to Asian patients, and the presence of anti-Rho ANA positivity is a little higher in Asian patients, and cryoglobulins, and when you see this as a whole, also cryoglobulins seem to be much lesser in the Asian present patients compared to the Western counterparts. I'll try to summarize my findings so far, whatever I discussed. So we need to understand that Sjogren's is probably not very rare in India. As rheumatologists, we might see those patients who have immune complex mediated diseases because of Sjogren's rather than pure Sika. That's why we might feel that we are seeing lesser number of Sjogren's patients compared to what we expect from the literature. And Indian patients are younger at presentation, and subject to Sika at presentation is quite less. Rather, they present with the organ manifestations, and high titer antibodies for role are associated with systemic manifestations. However, one caution we need to exercise while generalizing these findings is there are different methodologies and classification criteria used across these studies, and there is probably an underreporting of Sika by our patients, so they may not perceive that as a significant complaint itself to bring it to the attention of clinicians. And we need a good data from ophthalmology centers, I feel, to understand the exact prevalence of Sjogren's in India, and a very high degree of renal tubular acidosis, whether it's actually an occurrence or is it because of most of the Asian patients, they also use complementary medicine. So whether the complements or this herb-induced renal tubular acidosis, we need to factor in that. And very low prevalence of cryoglobulinemia across the studies I described, not only from India, from Asia, but we need to understand that cryoglobulin assay needs to be standardized, and whether it's lack of standardization that we are missing this cryoglobulin. And probably we need a global collaborative work to affirm the differences that I mentioned. Thank you.
Thank you, Dr. Pispati. This session is now open. and I invite questions.
Hi sir, thanks for the lecture. Sir, in the literature have you come across the difference in biopsy features between primary Sjogren's and secondary Sjogren's? What are the biopsy features?
Biopsy, well, secondary Sjogren's, I have not reviewed the difference between primary and secondary on biopsy. I don't expect it to be too different though, because its underlying pathophysiological mechanism should remain same. But I don't think I've reviewed any such data.
Yes, sir. Sometimes we generally see patients with polyarthritis presentation. RF is positive and APA is negative. Still we have suspicion of RA but not Sjogren's. Sometimes how to differentiate between whether it's Sjogren's or RA? Yes,
that's a good point. I think, but if it is non-deforming, probably it will go towards Sjogren's. That's how I'll take it. And one other thing, biopsy in secondary Sjogren's I usually don't do unless I have some other organ manifestation. So where I do biopsy, minor lip biopsy, probably someone with a neuritis or vasculitis where I'm confused about the diagnosis. So that's where I typically do. So most of the primary Sjogren's I end up doing a lip biopsy. Another important tool probably we can use is salivary ultrasound, parotid ultrasound, I'm sorry. So parotid ultrasound showing this typical hypoechoic grape-like structure, we expect to occur only in primary Sjogren's rather than in rheumatoid. So that's what I would do.
Thank you.
So that's
If no other question,
Dr. Prakash Das. He would be talking about the Indian data on Sjogren's syndrome and update.
Right. Thank you, Chairperson sir, for asking me to present on a very interesting topic. And thank you, Dr. Abhishek Patil, for a wonderful lecture. You made my life easier. You covered a few of the studies which I'm going to cover anyway. Well, I'm Dr. Prakash Das, consultant rheumatologist working in Calcutta. So my topic is Indian data on Sjogren's syndrome and update. So this is the overview of my talk. So I would like to cover on these 5 major domains like demography, clinical features including glandular and extraglandular manifestations, antibodies and biomarkers, therapeutics and patient perspectives, especially in Indian patients who are suffering from Sjogren's disease. I have included studies which have been published in PubMed index journals, and I have deliberately excluded abstracts, case reports, case studies, and the reviews. But my sincere apologies if I missed any interesting or important studies on my way. Now, there is a strong knowledge gap. When we think of Sjogren's disease, we always kind of picture a white Caucasian lady because most of the published literature and the scientific evidence what we have so far is based is from the West. But time has come, India has generated a lot of data because Indian population have different phenotype and different genotype, and the clinical presentation is somewhat different. So probably we need to know our data first before we can make a decision. There will be quite some difference. Now, to look at the demography of Sjogren's disease in Indian population, first question we have to ask is primary Sjogren's an uncommon disease in India? If we go back maybe quite a few years ago, in 1978, first study was published with Dr. Malviya's study, and they have reported only 6 cases for 10 years duration. Similarly, study from Chennai, Dr. Sjogren'S team, they have reported 3 cases of Sjogren's over 20 years, and they have labeled as rare disease. If he was, few years down the line, maybe 2003 area, 2 studies came up, one from SGPJ, one from Chennai. Dr. Ramnath Mishra sir's team, they have reported 26 patients, 10-year follow-up, and it showed female predominance, and the mean age was around 42. Similarly, from the Chennai cohort, they have 36 patients over a span of 4 years, and they have showed female predominance, and the mean age was really around 40. This is a large study which was mentioned from CMC fellow, Dr. Shanda Pulukul and Dr. Devasisanga. They have also noted younger presentation in the Indian population, which is probably slightly less than 10 years compared to European cohort or European patients. But the South Asian patients and Chinese patients, the age of presentation is almost similar to Indian, around 40. Again, there was significant female predominance in Indian population. So let's talk about the clinical features, both glandular and extraglandular. Again, I'm going back to the same studies from SGPGI and Chennai. If you just look at the data, dry eyes and dry mouth was prevalent around 80-90% of patients, arthritis around 75% of patients, antibody positivity around 65 to 70, both SSA and SSB. And the clinical and immunological profile was similar to the West, but there are few differences, like age of presentation is a lot lesser in Indian population. Now again, next question comes, how common is the Sikha symptoms? Dr. Patil has already focused that Sikha symptoms much lesser in Indian population. The study from CMC Vellore, the same study which I referred earlier, they have studied 332 patients. History and clinical examination revealed Sikha symptoms up to 90% of patients. Having said that, less than 10% of patients have volunteered Sikha symptoms on the first presentation. Again, similar, this study has been dealt with Dr. Patil as well, so I'm not going in details. So they have included 82 patients, out of which 62 had extraglandular manifestations, and 50% of the patients with extraglandular manifestations did not have Sikha symptoms. Overall, amongst all these patients, only 40% did complain of Sikha symptoms. Although after objective evidence like studies on various tests, they have found xerostomia and xerothermia. So I'm going big details on the study from CMC Fellow. I've discussed the Sikha glandular manifestations, but from extraglandular manifestation, renal involvement was found in nearly 14% of patients, and 8 patients had renal tubular acidosis. Respiratory symptom in 12% patients, neurology in 9%, hepatomegaly in 8%, hematological manifestations in 7%. This is quite widespread. That's slightly different from Western country. As Dr. Patil has already mentioned, they did a cluster analysis of clinical and immunological characteristics, and they have found 2 major clusters. So cluster 1 is Sikha symptoms with general and mild systemic manifestations, with some exceptions. They had some neurological manifestations of renal tubular acidosis. But the other second cluster is a major systemic illness with very high anti-Ro and LA antibodies. But these patients had very minor Sikha symptoms. Now, if you look at the extraglandular manifestations, and if you compare to the other countries, so in Indian patients, arthritis is common. Raynaud's is quite rare, probably because of the climate or in the southern India. Immunological tests were comparable compared to West and Chinese data, and there is paucity of coagulation. Not a single patient was reported. Probably, which Dr. Patil has said, there could be some technical issues or preservation issues. We have to look into that. They have also done a multivariate logistic regression regarding the predictors of systemic involvement, and they have found major systemic features were positively associated with antibody positivity like anti-Ro and anti-La. And association of anti-Ro and anti-La had a significant higher odds with skin manifestations and ANA positivity, and significant negative associations with polyarthritis or arthralgia. Sorry. So this study, which has already been mentioned, is a study looking at the secondary Sjogren's syndrome. This included 199 patients with rheumatoid arthritis, and prevalence of Sikha symptoms and secondary Sjogren's syndromes were 14% and 5.5% respectively. And if you look at the cohort with patients with rheumatoid and Sjogren's disease, the age of presentation, age of onset, and disease theory is slightly higher compared to the patients without secondary Sjogren, the rheumatoid patients without Sjogren's disease. If we compare this data from the rest of the country, so probably as the reported data goes, Indian patients, the rate of or the prevalence of secondary Sjogren's is probably lesser compared to European countries. Again, this is an interesting study from CMC Vellore. Again, they studied 275 patients, and they have seen all these patients have consulted more than 20 specialties on their first visit. And the median number of visits before the first diagnosis is 1 when there is a very strong suspicion of Sjogren's disease, and 3 or more if there is a not very convincing differential of Sjogren's on the first visit. So they have concluded Sjogren's is a challenging disease, which we all know. Initial suspicion was limited to nearly 50% or less than 50% in other specialties, and slightly higher, probably 65% in the rheumatologists. And they have mentioned the first impression of Sjogren's disease, specific inquiry about Zika symptoms, and ordering specific antibody tests like ANA, ROLA antibodies. They are the strong predictors of early diagnosis of Sjogren's disease. Now let's focus on the extragranular manifestations. This is a study from JIPMER, which Dr. Patil has already informed, so I'm not going in details. So they have studied 70 patients. Out of them, 50% of patients had renal manifestations, and 25 had complete renal tubular acidosis, 4 had incomplete renal tubular acidosis. Commonest clinical manifestations were hypokalemic periodic paralysis. They underwent renal biopsy as well, and tubulointerstitial nephritis was noted in 9 patients. So in the renal group, there were lesser manifestations of Zika symptoms, articular manifestations, but they had higher cutaneous vasculitis and anti-ROA possibilities. And they have suggested for should I not here?
Yes.
Probably this is the
What problem?
Time schedule has been changed or
that is probably from the previous one, so it's 9 minutes showing stuff. Right, so the author they have suggested renal biopsy for all patients with suspected renal disease. Now this is a study for the Sjogren'S, study from NIMS Hyderabad. They have studied the patterns of peripheral neuropathy in Sjogren's disease, and they have identified 8 patterns, out of which mononeuritis multiplex is a majority, 30%, followed by ganglioneuropathy with sensory ataxia in 20%, followed by trigeminal neuralgia, length-dependent sensory neuropathy, CIDP pattern, autonomic neuropathy, etc. And they have found neuropathy is a frequent presentation which is very often missed, especially subclinical. Most common is mononeuritis multiplex, and ganglioneuropathy and non-length dependent neuropathy is unique for Sjogren's disease. Again, a study from CMC Vellore. They have studied the clinical spectrum, therapeutic outcome, and prognostic predictors, which is an interesting study. But in this study, sensory ataxic neuropathy was the major predominant presentation, followed by sensory neuropathy without ataxia, mononeuritis multiplex, and radiculopathy. And they have concluded that sensory ataxic neuropathy associated with greater severity and autonomic dysfunction. All the patients were treated, they received immunosuppressive therapy, but 61% of patients responded well, and cranial neuropathy and radicular neuropathy had a best response. So another study we recently published a few months ago from PGI Chandigarh, they have studied 67 cases with 50 primary Sjogren's and 17 Sjogren's syndrome. And they have found that in primary Sjogren's, prevalence of peripheral neuropathy is 56%, which is higher than secondary Sjogren's, which is around 35%. And 50% of patients remain asymptomatic. And polyneuropathy was the most common presentation. But having said that, patients with peripheral neuropathy had a significantly poor quality of life, which has reflected being drop in 6 domains in the SF36 score. Again, for the study from CMC Vellore, they studied the audiological profile in primary Sjogren's. They studied 37 patients. They have done pure audiogram, tympanogram, and acoustic reflex testing for all these patients. And sensory loss was noted in 78% of patients, and only 17% had a subjective hair loss. So the commonest type is mild sensory neural hearing loss, and which occurs within first year of onset, and most of the patients are subclinical. And there were no correlation between hearing loss, age, sicker symptoms, and symptoms in this cohort. Let's come back to the antibodies and biomarkers. Again, study from PGI Chandigarh. They have correlated, found the association between immunological and clinical presentations. In this study, interesting thing is, although the xerostomia and xerophthalmia was almost comparing to other Indian studies, arthralgia, arthritis was slightly lesser, and 65% of patients, but renal involvement is quite high, on 30% of patients. And they have concluded ANA positive patients are younger and have renal involvement. Anti-Rho is associated with younger age, renal involvement, and high disease activity score. Anti-Rho is associated with high renal disease and low articular manifestations, and rheumatoid associated with hematological manifestations, and hyperglycemia is associated with very younger age group. So this is a study interestingly from CMC Vellore. So anti-muscarinic acetylcholine receptor 3 is one of the most prevalent antibodies. There are quite a few studies from China and Japan. They have found patients who are anti-Rho and negative, and they strongly had sickness symptoms. Anti-muscarinic acetylcholine anti-ACR antibody was positive. But in this study, there were relatively lower prevalence of salivary anti-MR3 antibody, is 55%, which is slightly lesser than other studies in the South Asian countries. If you don't know, CXCL313 is a beta cell attracting chemokine, which helps in the organization of beta cells in the lymphoid follicles. Most of the studies have shown higher levels of both salivary and serum, but in this study, the serum CXCL3 was higher, but not the salivary CXCL3 levels. And CXCL3 positivity has to do with oral symptoms, ocular signs, and hyperglobulinemia. Similarly, soluble L-selectin and interleukin-7, they are adhesive molecules and inflammatory chemokines. So high salivary L-selectin and interleukin-7 levels were found in Sjogren'S patients compared to healthy individuals. Let's come out for therapeutics. I can find only one study. They have studied the effect of curcumin in inflammatory response to Sjogren's disease, and the curcumin reduces gene expression IL-6 and interleukin-1 beta, as well as secretion of interleukin-6 from the minor salivary gland in Sjogren's patients. But not the less the patient perspective. We only think about patient's symptoms or our perspective, like joint pain, joint symptoms. This abstract was published in this Iracon 2022 by the patient support group. So Ms. Kirti Naoza is the patient lead. There are really around more than 200 active members in the group. They are all patients suffering from Sjogren's disease, but only 123 of them has filled the form. According to them, what they have identified, we doctors are mainly worried about arthralgia, myalgia, systemic manifestations. But patients are mainly worried about the gastrointestinal symptoms, gynecological manifestations, psychological disease. So there's quite a bit of mismatch. So our perspective is probably slightly different from patient perspective, which has to be taken into consideration. So this is the Sjogren'S India group, which is running on really well. They have more than 400 members, but around more than 200 active members at this point in time. Right, so just to summarize my last slide. So we have substantial Indian data on Sjogren'S at this point in time, but sky is still high. We need to work more. We have to generate more data. How are we different from the West? Indian patients are younger. There's higher female to male ratio. The paucity of sicker symptoms. There are lesser Raynaud's, probably because of the climate or weather. They have lesser articular manifestations compared to the Western counterpart. Renal manifestations are more, especially irritable acidosis, and antibody prevalence is slightly higher side. But just to say for certainty, we need more research collaborations, randomized control trials, and more patient involvement. Thank you very much.
What is HPP?
It's a hypothalamic pericarditis. I'd like to acknowledge Dr. Sandha Pulukul, Dr. Swapan Pandya, Professor Naidu, sir, they have literally helped me building these slides, and they have shared their studies with me as well. Thank you very much.
Glandular syndrome, that means dry eye, dry mouth, we seldom get it. But hypokalemic pleuritic paralysis, almost 1 to 2 per unit in every medical college. And recently I got one case of sensory ataxia with Sjogren'S syndrome. So complicated Sjogren'S syndrome with renal and neurological involvement must be our card on cases of pleuritic paralysis and pure sensory ataxia.
Thank you, sir.
Thank you so much.
Thank you, sir. Thank you.
Against these muscarinic receptors or redistribution of aquaporin 4. Have you found any case?
So I'm just quoting this study. I haven't got my personal experience with this, but I think in the Eastern countries like Chinese and Japanese population, they are well done. There are quite a few studies they have quoted when patients have strong symptoms of Zika symptoms, and they are anti-Rho and anti-LAS negative. They can have anti-muscarinic acid receptor antibody positive. But this didn't show up in our study in same below.
One more question. How common is autonomic neuropathy? I might have missed.
No, I think the study from NIMS, they have found autonomic neuropathy, especially with sensory ataxic neuropathy, that is more common. But I think they haven't quoted the prevalence of autonomic neuropathy there, so probably that is more research.
Dr. Patil?
Sir, the neuropathy itself is quite common, but autonomic neuropathy from whatever literature I got is around 3 to 5%, but not from Indian data that I've got.
You don't have Indian data so far.
So thanks to... Yes, sir.
Dr. Das, one thing, we look from rheumatologist's point of view as Sjogren's syndrome and lymphoma. On the other hand, if you look at the lymphoma series, how many cases of lymphoma patient get Sjogren? Do you have any data, Indian data? There are a lot of cases of lymphoma, diffuse follicular lymphoma.
No, sir, I don't think we have. I had a chat with Dr. Porkudi madam. Dr. Mohana Sundaram madam is already presenting a case
It should be
today.
interesting because lymphoma, they don't quote that. With the oncology conference or meeting, hardly they mention about the Sjogren in lymphoma. But we talk about the lymphoma as an extraglandular manifestation.
I don't think we have the data so far.
Dr. Patil?
Nice thought, sir. I think we should look into it. But only problem is whether it's a secondary manifestation of the lymphoma. It's hard to differentiate. I mean, if the patient goes to oncologist and he complains of Zika, whether it's just a secondary manifestation of Sjogren's, rather than Sjogren's itself leading to lymphoma, it's a hard thing to prove.
Probably it's a lymphocytic
They
infiltration
never
of the
quote
gland
it
which is
actually.
causing.
No, what Sat told is 100% correct. If you see the latest classification of Sjogren's by Manchester classification, there are 4 types. And the type 4 is that Sjogren's which transform into lymphoma. They, on each lymphoma, they perform the Sjogren's test in a retrospective. And probably, I have read it 6 months ago, probably 5% they got the Sjogren's antibody. So, here, if we test in every lymphoma the Sjogren's antibody, we will also get this. But it will be done in a structural fashion.
So let's move to the next session, that is vasculitis.